वो मैं करा दूंगा।
ओके, क्या दो
हाँ, हो गया, मैं अभी करूँ।
अच्छा, कैन आई स्पीक? हाँ, रिपु जी,
रिपु सर, वो सुन रहे हैं, मेरे तो फोन पे कनेक्टेड है, आप बताइए।
अच्छा रिपु जी, हमको 5 लोगों को कनेक्ट करना है। एक तो डॉक्टर मोइनक आ गए हैं, ठीक है, डॉक्टर यूसी घोषाल हैं,
घोषाल सर हैं।
अच्छा, और तीसरे हैं डॉक्टर निरुपम वर्मा,
निरुपमा वर्मा,
निरुपम वर्मा,
निरुपम वर्मा,
निरुपम वर्मा,
उनको
और
भेज दिया है फाइल?
डॉक्टर
हाँ।
आभा गुप्ता,
आभा गुप्ता,
ठीक, डॉक्टर संजय टंडन
संजय टंडन,
और डॉक्टर भल्ला।
डॉक्टर भल्ला।
बस
ठीक है
हम
सर?
लोग, हाँ, वील बी द 5-6 पीपल, बाकी सब म्यूटेड रहेंगे
आपने म्यूट कर दिया।
अभी।
Good evening, Dr. Anita.
Hi, how are you, Dr. Nirupam? Unmute yourself.
Just fine. I believe I am in time. We'll begin at 5.
Yeah, we are just going to start in another 5 minutes, 4 minutes.
5 minutes. No problem.
Okay, good. So you're going to introduce the speakers because Dr. Abha Gupta still hasn't joined.
Okay, fine.
She's joined.
No problem.
So,
I'll
so
begin. First talk would be Dr. Ghoshal. Dr.
So you
Ghoshal.
introduce Dr. Ghoshal and Dr. Abha will introduce Dr. Moina. You got this?
Dr. Abha has just joined. I believe she's there. I can see that.
She's not joined the audio. She's not joined the audio.
Fine, not a problem. I'll introduce.
Mine audio.
Okay. All right. Dr. Abha, can you hear me, Dr. Abha?
Hello.
Hi, Dr. Abha. I can't see you. Where is your video? Where is your video?
Okay.
Yeah. Hi.
Hello, ma'am. Hi. Hello, ma'am.
Hi, good to see you and good to know you. Dr. Abha, Dr. Nirupam Prakash will be introducing the first speaker. That's Dr. Yusi
Okay.
Ghoshal. And
Okay,
you
okay.
can introduce the second one.
Okay, okay. Okay, ma'am.
All right.
That's fine.
And you have the CV slides
Yes,
of these?
yes. I have the CV of both the speakers.
Oh, okay, great, great, great. This is Dr. Moinak. I can't see Dr. Moinak.
Hi, Dr. Nibram.
Hello, ma'am. Hello.
Hello.
Hello,
This is
everyone.
Dr. Moinak. Have you met him before?
Hello, everyone.
No, he's Dr. Moinak from our pediatric gastroenterology department. And Dr. Ghoshal is also joined.
You can see Dr. Ghoshal. I believe he's there. Good evening, Dr.
Hi.
Abha.
Hi. Hi. Good evening, Dr. Prakash.
Join
Good evening, Dr. Manak. How are you?
Hello.
Sanjay Chandan.
How are
Good
you,
evening,
sir?
Dr. Ghoshal, sir.
Good evening. Good evening.
How are you, sir?
I'm fine.
Good. So you are the first speaker?
Okay.
Hello,
Yeah,
sir.
right. So time ho gaya? 6, is it? All right, 1 minute more to go. Good evening, Dr. Sanjay Tandon. Good evening, Dr. Sanjay. Unmute yourself. Your time. Shall I start? Unmute. Yes, Dr. Sanjay. Yeah, you are connected.
Yeah. Good evening.
Yeah, good evening, Dr. Sanjay.
Good evening, Dr. Anita. Good
Yeah.
evening, Dr. Ghoshal. Good evening.
Good evening. Good evening.
Hello, Abba.
Hello, sir.
Good to see you.
Dr. Sanjay, this Dr. Moina, can you see
Hello,
him?
sir. Hello, how are you, sir?
Dr.
Moina.
Mayank Sen. Yeah.
Hello,
Hello,
sir.
Dr.
How are you,
Mayank
sir?
Sen.
Yes, how
Hello.
are you doing, sir?
And Dr. Nirupam, have you joined in? Nirupam? I think.
So can I start?
Yeah, I think Nirupam
Yeah.
is there.
Good evening, sir.
Good evening, Nirupam. Good evening.
So
Yeah, Dr. Anita, I think we can go ahead.
yeah, we can start. Right. Good evening, ladies and gentlemen. On behalf of Society of Renal Nutrition and Metabolism India and UP Association of Physicians of India, it is indeed my pleasure and privilege to welcome you all to the second session of Continuous Medical Education Program on Touching Basics of Nutritional Intervention. For those who are joining us for the first time here today, I would like to inform them that we are organizing this activity on every first Sunday of the month between 6 p.m. and 8 p.m. And with me are Dr. A.K. Balla, President SRNM India, and Dr. Sanjay Tandon, Honorary Secretary, UP API, and Secretary, Association of Physicians of India, Lucknow. Now, the Society of Renal Nutrition and Metabolism is committed to preventing malnutrition in patients with chronic kidney disease. Chronic kidney disease is not a single entity, and its management is, therefore, its management is complicated by presence of various comorbidities like diabetes, cardiovascular diseases, malabsorption syndrome, and surgical emergencies. We in renal units are mainly focused on the management of renal crisis and are not so well versed with the management of complications related to other specialties. In this CME, we will therefore be covering topics related to irritable bowel syndrome and liver diseases in adult patients and stomach, liver, and liver disorders in children. Now, the aim of the CME is to streamline nutritional intervention across the country in CKD patients with due credence to associated comorbidities of CKD. There'll be 3 lectures today, and each talk will be for 30 minutes, followed by a panel discussion. Now, the panel discussion, for panel discussions, we have Dr. Nirupam Verma and Dr. Abha Gupta.
Nirupam Prakash.
Yeah, that's okay. No problem.
And Dr. Abha Gupta.
Can I have this?
Yeah. Is Nirupam here?
Right.
Yeah.
Yeah. Right.
All right. Dr. Nirupam Prakash is consultant physician. He's based at Lucknow, and he's MD, FICP, PGCC Diabetology, and PGCC Cardiology. He's treasurer and member Executive Committee API Lucknow, Joint Secretary API UP Chapter, and Secretary API, a faculty and member organizing committee at state and national level conferences API, UPDA, CON, RISTI, DIPSI, and ACP. He is the editorial board member of IGMS and assistant editor case reports from the tropics, and is reviewer for Indian Journal of Medical Specialties, Universal Journal Education, and from the tropics. He's for case reports from the tropics. He's reviewer for Indian Journal of Medical Specialties, and he's been awarded FICP 2014 award and Padmakar Tripathi Award, and the Unite for Diabetes Program of Indian Diabetes Federation Award. And he's won Best Paper Award at UP Diabetic Association Congress 2011. And he has more than 30 articles to his credit in the national and international journals, and 21 chapters and reviews that he has published. Dr. Abha Gupta is Professor of Medicine, Government Medical College, Saharanpur, UP. She has received Fellowship of Indian College of Physicians, IACM, CM, and Diabetes India. She's received Bharat Jyoti Award in 2015, IACM Professor B.C. Bansal Best Paper Award in the year 2016, and Investigator of the Year in 2017 and 2018 awards by Indian Society of Hypertension. She's an expert. She's a member of expert panel for Lipid Association of India recommendations, which makes recommendations on dyslipidemia, published in JAPI in 2016 and 2017, both for Part A and Part B. And she's member governing body of UPAPI, RISTI, UP chapter, and UPDA. She's published 6 chapters in various books, and she has several research publications in international and national journals to her credit. Now, I would request the panelists to please introduce the first speaker.
Thank you, Dr. Anita. Thanks for the wonderful introduction. And moving on to our scientific session tonight, I'll have the privilege to introduce Dr. Uday C. Ghoshal. He's a professor, Department of Gastroenterology, SGPGI, Lucknow. And he's also the president of Indian Motility and Functional Disease Association, the editor-in-chief for Indian Journal of Gastroenterology, associate editor for digestive diseases, Journal Neurogastroenterology and Motility. He's a senior editor at the Journal of Digestive Endoscopy and an advisory board member, Nature Reviews Gastroenterology Hepatology. He has, to his credit, published 310 papers in different international and national journals, and has, to his honor, total citations of more than 11,000 and an H index of 55. And he's the only and the proud president in criteria, former chair for the Rome Foundation International License Committee. It's a privilege to have you here, Dr. Ghoshal, and I invite you to deliver your talk on the first topic, which is on fundamentals of therapeutic nutrition in adult patients with IBS and liver disease. Dr. Ghoshal, please.
Thank you. Let me share my slide first. Thank you, Dr. Saxena, for giving me this opportunity. I'll be talking about diet in irritable bowel syndrome and liver disease. Now, let me start with a patient. This is a 28-year-old who was an MD student of gynecology and obstetric doctor doing her postgraduate in Hyderabad. And she came to us with the following symptoms. These are abdominal discomfort and feeling of distension of the abdomen for 3 to 4 years. She had flatulence, irregular stool form and frequency. Sometimes she would have loose stool, maybe 4 or 5 times a day. And sometimes she would have even constipation and would not pass stool for 2 to 3 days. And when she used to pass, the stool used to be hard. She had mucus with stool and she had feeling of incomplete evacuation. I tell you, if you tell this story to any physician, he knows the diagnosis. How does he know the diagnosis? There is a condition called irritable bowel syndrome. And how is irritable bowel syndrome diagnosed? When somebody has recurrent abdominal pain, at least 1 day per week, also in Rome 3 criteria is recurrent abdominal discomfort, in the last 3 months, associated with 2 or more of the following related to defecation. That means her problems are related to defecation. Her abdominal discomfort and pain is related to this defecation. Associated with the change in the frequency of stool, as I told to you, our patient used to pass sometimes 3 to 4 or 5 per day, sometimes would not pass for days. And associated with the form of stool, change in the form of stool or appearance of the stool, she used to have liquid stool sometime, she used to have hard stool sometime. And the onset should be at least 6 months ago. Our patient actually fulfilled everything. Now, what is required for the diagnosis of IBS is there should not be alarm feature. What are the alarm feature? If the symptoms start at the age more than 45 years, why do you say so? Because this patient, if somebody start having GI symptom after the age of 45, you think, is it a GI cancer? Anemia should be absent. There should not be blood in the stool. Patients should not lose weight. Nocturnal symptom, if the patient gets symptoms at night which disturbs her sleep, this is not IBS. She should not have fever, abdominal mass, and family history of cancer. So all these our patient did not have. Now we subtype IBS. IBS can be constipation predominant, where primarily the patient's symptoms are constipation. IBS can be diarrhea predominant, when primarily the symptoms are diarrhea. IBS can be even alternating, where you have diarrhea for some time and constipation for some time. Now, our patient did not have any of these alarm features. So if I ask you what is the diagnosis, I know you will say irritable bowel syndrome. If I ask you what is this type of irritable bowel syndrome that our patient had, you will say it is alternating, because sometimes he's having constipation, sometimes he's having diarrhea. So it is too easy to talk about. But let me tell you, when we went deeper into the story of the patient, we got some information which help you to manage this patient better. What was the information? She says that when she is at Hyderabad, her symptoms are much less. But when she is at Lucknow, she belonged to Lucknow. So whenever she would come to home at Lucknow, her symptoms are more. Now, what could be the reason? What could be the reason that why our symptoms are less in Hyderabad and more in Lucknow? One would say that is it related to the psychological stress? Because everybody talks about psychological stress in a patient with irritable bowel syndrome. So typically you get carried by whatever others say. So is it psychological stress? I tell you it is unlikely. Because stress is expected to be less at home than in hostel. In fact, her mother is very loving mother and she's very attached to her mother. Rather, she misses her mother when she goes to Hyderabad and lives in the hostel. She denied having much stress in either place. She's a very strong lady. If you talk about stress, she would say maybe the doctor is stressed more than me. She disliked consultation with several physicians who sent her to psychiatrists. Even she told me, I thought they should have consulted psychiatrists because she is a doctor herself. She said, I'm a very person of very strong personality. I do not have any psychological issue. Now, could it be related to dietary variation? Very much possible. Because we all know that in southern India, diet is primarily rice-based. You keep on eating dosa and idli and whatnot. You don't get this bread often there. Wheat-based diet is there in the northern India. She also said that she likes paneer very much. And each time she comes to home at Lucknow, her mother will give a lot of paneer to her. So she gets a lot of chapati and paneer because paneer is the one who she likes most. Now, therefore, could it be that this paneer and roti is causing her symptoms? Possible. Because what we saw, stress was not there in either place. Stress is less likely to be in Lucknow with her mother. Now, we wanted to test biologically whatever we were thinking, whether we were right or wrong. We did a lactose hydrogen breath test and a lactose tolerance test. And these two tests revealed that she had lactose malabsorption. We also did a fructose hydrogen breath test, and that revealed that she has fructose malabsorption. So how do we do this test? What we do is that we have a machine called hydrogen breath test machine. So in that machine, what we do is that we take a baseline breath hydrogen. So when the patient comes to you in fasting state, you take the hydrogen values in the breath, and then you give her lactose, that is lactose hydrogen breath test. You give her fructose, that is fructose hydrogen breath test. Then every 15 minutes, you do a hydrogen estimation in the breath. Suppose if you give this substrate to the patient, this substrate, if they are not digested, for example, in case of lactose malabsorption, we all know there is deficiency of the enzyme called lactase. So therefore, small intestine does not digest lactose. So it goes to the cecum. Now from cecum, hydrogen is produced because fermentation of carbohydrate by bacteria by anaerobic glycolysis results in production of hydrogen. Also, it produces methane. And we have this machine, which is the gas chromatograph, which gives us the value of hydrogen. So if hydrogen is high following lactose ingestion or fructose ingestion, you say this patient is positive for lactose malabsorption. So she had lactose malabsorption, she had fructose malabsorption, and she improved on withdrawal of milk and milk product. And she now we had to tell her that you have to prefer rice over wheat. One is to be aware that hidden lactose intolerance is there in several food products. So there could be several food products which, if you do not read the label, you realize that food product has lactose. Similarly, when we talk about fructose intolerance, compared to rice, wheat has more fructose. So she was having a lot of wheat, she was having a lot of paneer, and that was causing her symptom. In fact, she liked the consultation with us because she said, this is the first time somebody looked at the biological mechanism of my symptoms rather than blaming my mind for it. Now, therefore, I want to show this slide. This was the common view of functional gastrointestinal disorder. People thought that these are neurotic patients. They don't have any disease, they unnecessarily complain. But let me tell you, most patients dislikes this, and even our patient also dislike this. So when an IBS patient come to a doctor clinic, let me tell you, typically patient ask the doctor, what should I take? What should be my diet? So typically doctors said small and more frequent milk, low fat meals, low fat diet, avoidance of smoking, alcohol and caffeine, avoidance of non-steroidal inflammatory drugs, avoidance of carbonated drink, avoidance of irritating food. And there was an Asia Pacific survey in which it was found, interestingly, 95% dispense lifestyle or dietary advice to functional dyspepsia patient. But for IBS, this dietary advice was practiced less often. So that means patient want to know what should I eat, but the doctors don't know what patient should eat and what should patient avoid. So patient question are usually, what food should I avoid? What can I eat? Should I eat more fiber? Can I drink milk? How to reduce bloating? What causes gas? These are the usual patient questions. Now, this is one of our study where we looked at frequency of lactose malabsorption among IBS and healthy subject. And we found frequency of lactose malabsorption among IBS and healthy subjects was comparable. But interestingly, following a lactose load, IBS patient developed more symptom compared to healthy subjects. And also look at this study in which we compared the Southern Indian healthy subject and the Northern Indian healthy subject. I know this is a national CME. So remember one thing, if you are in Southern India, the frequency of lactose malabsorption will be more in Southern India than the Northern India. In fact, in Southern India, frequency is to the tune of around 80%. In Northern India, frequency is to the tune of less than 60%. I can't actually explain what is the reason now because I have not so much time to talk about. Now, question is, second is, there is a term called non-celiac gluten sensitivity. Non-celiac gluten sensitivity is very, very sort of popularly talked everywhere in the world. And a lot of people in the world, they actually open gluten-free diet shop to earn more money. And unfortunately, if you taste those dietary products, you'll find many of these products actually has gluten, a lot of gluten. What does it mean? The gluten-free diet has become a fashion now in all IBS patient or many other diseases. Maybe this is the market force or business pressure rather than the true frequency of advantage of due to gluten-free diet. Now, this is a study which showed that if you take patient with IBS and stop their all sorts of wheat product, and now they improve. And after they have improved, 19 were randomized to receive gluten and 15 received placebo, and they found both had recurrent symptom. Both group had recurrent symptom, but those who received placebo also had recurrent symptom as frequently as those who received gluten. It was pure gluten. So therefore, this author suggested it is not the gluten which is responsible for every ailment in patient of IBS. It is the wheat, because wheat has many other substances than gluten, and one of them is fructose. And I told you our patient had fructose malabsorption as well. That's why now in the world, we change the term non-celiac gluten sensitivity to non-celiac wheat sensitivity. Now, how common is fructose malabsorption among IBS patients? This is one of our study from our center. We found 14% of IBS patients were fructose malabsorber compared to 2% of healthy control. Now, whenever somebody actually malabsorb this disaccharide or polysaccharide in the small bowel, this carbohydrate will reach colon. And this will result into bacterial fermentation. And this bacterial fermentation produce osmotically active substances, which may cause diarrhea. It may cause a lot of gas production, which will cause distension of the bowel, therefore bloating, and even the distension, when it becomes very marked, this will be experienced as pain. So therefore, you have to understand this is the mechanism of symptom among these patients. Now what world have seen is that lactose is only a component of all the intolerant food that the patient experience. So these food groups are called fermentable, oligo, di, monosaccharide, and polyol. In the short form, they are called FODMAPs. So FODMAPs not only include lactose, not only include fructose, many more, like I'm talking about sugar, alcohol, and all those. Now, what these FODMAP food they do is that they are not digested in the small bowel, therefore they reach colon where they produce gas, and that leads to all the mechanism. And these are fructose, lactose, fructans, galactans, and polyols. So you can see what are all the dietary ingredient has this, like fruit sugar, milk sugar, fiber, sorbitol, mannitol, and so on. And there has been at least 9 studies. This slide is a little old. There has been 9 high-quality randomized controlled trials in the world now to show that if you stop FODMAP, a good proportion of patients with IBS improve. Now, these are the low FODMAP food. This is a diet chart which I just created and put in our educational website for the patient. This is spreadhealth.in. Sorry for this. This is now the web address is changed to www.spreadhealth.in. And you can see these are all low FODMAP food. What are the high FODMAP food? These are the high FODMAP food. These are the high FODMAP food. So patient is supposed to stop or reduce the high FODMAP food. And this is one of the first trial which was done from Australia, Peter Gibson group, which was a randomized controlled trial to show that low FODMAP diet led to improvement in IBS symptom. 70% was the response rate to low FODMAP diet, 50% had reduction of symptom, benefit all 4 subtype of IBS, that is diarrhea, constipation, mixed and unclassified. Control subjects were not improved, and obviously some people raise the issue of blinding because dietary studies have difficulty with blinding. Now, can we practice this low FODMAP food in India? Because India, a lot of people are vegetarian. Second is our curries have a lot of those garlic, onion and whatnot, which a lot of beans, and these are all high FODMAP food. So is it easy to practice low FODMAP diet in India? Difficult, very, very difficult. But let me tell you, studies are coming. Now, there is a study which has been published in this month only from DMC Ludhiana, which was a randomized controlled trial of low FODMAP food in diarrhea predominant IBS, and the author got a positive result. So low FODMAP diet in IBS, there is a clear utility, but there is need for more Asian data. Tend to be more expensive, may develop food obsession in patient with IBS. It is overly restrictive. Also, it can change the gut microbiota. Whether long-term dietary therapy of this kind will be easy or not, we have to see. So therefore, as you can understand, the IBS is a disease, or functional GI disease is a disease which need multi-dimensional management. And in fact, I liked when Professor Saxena said that actually we know a lot about nutrition in renal failure, but we need to learn in the other specialties. Gastroenterology was one specialty which has nutritional issues as the main thing, because we all know that on an average, we eat 500 kilo food every year. So a human being eats 500 kilo food every year, and this much he has to digest. So therefore, diet will be a very, very important component of any GI disease. Now let us come to liver disease, because time is not much. I'll speak briefly. What I will say is liver disease has a lot of incorrect belief among people. Like we see all the viral hepatitis patients, every diet is stopped. They will be given only boiled diet. People even avoid turmeric in them because they think that turmeric is yellow, and in jaundice patient become yellow, therefore it should be avoided. So we have to work in the society to popularize that these beliefs are absolutely wrong. So what happens is I'm going to touch on only 2 diseases. One is cirrhosis of liver, and other is non-alcoholic fatty liver disease. Interestingly, cirrhosis patients often are malnourished. On the other hand, non-alcoholic fatty liver disease typically develop among people who are obese. Now, you will say cirrhotic are often malnourished. What is the proof for that? And in fact, Professor Saxena, we can do such a study very easily. Look at this. This is a study from GB Pant Hospital, Delhi by Professor S.K. Sari. He took 67 patients with alcoholic liver disease. He took 52 alcoholics, no liver disease on biopsy, 44 non-alcoholic cirrhosis, and 52 healthy subjects. What he found? Protein allergy malnutrition is common in both alcoholic and non-alcoholic cirrhotic, but is more pronounced in the latter. So non-alcoholic cirrhosis had more protein allergy malnutrition. The degree and the profile of malnutrition in chronic alcoholic and in alcoholic cirrhotic are comparable. Why is it so? That is because a lot of alcoholic, they derive their calorie, almost half of their calorie from something like from the alcohol itself. So therefore, alcohol doesn't have, it has only calorie, and it is missing in every other thing which a person needs. Now, what should be avoided by the patient? I tell you, anything which has a lot of salt should be avoided. The reason is that patients of cirrhosis has ascites. And ascites, we try to reduce their sodium by giving diuretic. We want to excrete sodium by giving diuretic. And if you give something which has a lot of salt, for example, pickle, for example, a lot of other soup, which has a lot of salt. Now, what will happen is they will retain more and more water and it will be difficult to manage them. Why they should avoid like meat, I'll tell you, one of the thing is meat, when somebody cooks, it requires a lot of salt and other ingredient. But more important than that is the concept of branch chain amino acid versus aromatic amino acid. So what they should eat, they can eat vegetable freely. The protein from the plant source should be preferred over the animal source. Though milk is okay, but when you talk about meat, this is not the great protein to take. In fact, many of the cirrhotic patients who have large porta-cavale sand, typically get a history. They go to a party, eat a lot of meat and chicken and whatnot, high protein meal, and then they develop encephalopathy in the night. They get admitted to our ward. We purge them with a lot of lactulose, and the next morning they are up and they are discharged. What does it mean? That whenever somebody takes huge amount of protein, it produces ammonia. Now, we all know that urea is produced from ammonia in the liver, and these people have cirrhotic liver. Their liver doesn't function well, so therefore urea is not formed from ammonia. Also, because there are large collateral vessels through which this ammonia passes and they go to the brain, and that leads to encephalopathy. Avoid alcohol, avoid salt. This is very, very important. If somebody has alcoholic liver disease, one of the major challenges is abstinence. And if somebody has non-alcoholic liver disease, still they should avoid alcohol because alcohol is bad. Why branch chain amino acid is good? Because branch chain amino acid are less ammonia-genic. We give this concept, but I know my time is up, so therefore I'll take only one more minute. What do we give? See, when somebody has ascites, he has a lot of water inside his tummy. Now, what is happening is he's pouring water every day in the form of drink, and we are trying to excrete this extra water by giving diuretics, which increases the urine flow. Now, until unless patient restrict water, so I'll keep on giving more and more diuretic, which will cause hyponatremia, but his ascites will not reduce. The reason is that he's not restricting water. Diuretic is causing a lot of diuresis. He's feeling thirsty and he's not reducing the water. So therefore, it is very important concept that we will increase the urine output by diuretic, but he also has to reduce the water content. This is in contrary to renal failure patient. When you say this is your obligatory loss every day, and over and above you take 600 to 700 ml every day, we say no, you have to have a negative balance. If you have a past urine of maybe 1800 ml, take water maybe 12 or 1300 ml. In non-alcoholic fatty liver disease, they are often obese, and it is important to control their diabetes and obesity. So I could not touch a lot on alcoholic liver, on liver disease patient, but let me tell you again, liver disease management is multidimensional, and dietitian nutritionist plays an important role there. And unfortunately, in gastroenterology, we need the helping hand of Dr. Saxena, Anita Saxena, because interestingly, our gastroenterology department doesn't have a nutritionist. Thank you so much.
Thank you, Dr. Kushal, for an excellent deliberation on the use of nutritional assessment in IBS and liver disease. Dr. Anita, shall we take the questions right now, or we'll have it after both the sessions?
In the panel discussion?
In the panel discussion, I'll request. Okay, fine enough. I'll request my co-chair, Dr. Abha Gupta, to introduce the speaker for the second talk. Dr. Malik.
Thank you, Dr. Nirupam Prakash.
It's my pleasure to introduce one of the esteemed faculties of SGPGI, Dr. Monik Sen Sharma. He is assistant professor in the Department of Pediatric Gastroenterology, SGPGI, Lucknow. He has published several research papers and wrote 22 chapters. He has received various scientific awards in both national and international conferences, including R.K. Sharma and Professor S.S. Agrawal Award, and one of the esteemed award, Dr. Om Prakash Award from Indian Society of Gastroenterology. He also had the position of executive member in the Indian Society of Pediatric Gastroenterology, Hepatology, and Nutrition in the year 2016 and 17. So I invite Dr. Monik Sen Sharma to please start his deliberation.
Hello, am I
Hello?
audible? Am I audible?
Yes, sir. You can start your deliberation.
Thank you, Abha Gupta madam, and many thanks to Anita Saxena madam for giving this opportunity. I have two presentations. The first one is on the nutritional requirements in liver, and the second one on the luminal diseases. So, if you look at the paradoxes and diet in liver disease, on one hand, as Dr. Ghoshal has very elegantly shown us, on one hand, we have cirrhosis, where the patient is malnourished, emaciated, and we are encouraging dietary intake. On the other hand, we have non-alcoholic fatty liver disease, where the patient is obese and we have to restrict intake. And what is true for adults is the same for children here. On the other hand, you look at acute viral hepatitis, where, in India, there are a lot of dietary taboos, families deliberately restricting everything. And a fourth component, which adults don't have, but in children we have, is metabolic liver disease, where the nature is deliberately restricting certain food items. And I'll show you the same. If you look at the liver and kidney diseases that are combined together, and there are some common conditions. There are some which present with glomerulopathy that like hepatitis B and C, Wilson disease on chelators, autoimmune liver diseases that have immunosuppression, and these disorders but present as hematuria or nephrotic-like state. If you look at tubulopathies, galactosemia, hereditary fructose intolerance, tyrosinemia, glycogen storage diseases, again Wilson's disease, all these present as rickets and growth failure. Then you have other conditions such as cirrhosis with hepatorenal syndrome, Wilson's disease with pigment nephropathy, primary hyperoxaluria, where the problem is in the liver, but the kidney is compromised with stones. You have rare syndromes like Alagille syndromes with renal dysplasias and Carrelli syndrome with congenital hepatic fibrosis, and they also have polycystic or medullary nephrocalcinosis. The nutritional requirements in cirrhosis, first problem is hypoalbuminemia, that is a part of your sarcopenia, poor muscle mass, there is edema, ascites, bone loss, and you can achieve that by giving a high protein diet, albumin, calcium. The second problem we have in children is a bile salt and fat deficiency, where children have weight loss, skin issues, night blindness, oral ulcers, all multivitamin deficiencies, and you can supplement them with medium chain triglycerides, fat soluble and water soluble vitamins. The third issue we have is high energy consumption that leads to fatigue and poor growth, and you have to give them a carbohydrate rich diet. There are some additional problems in cirrhotics. Patients have portal hypertension, they have blood loss, which is of overt or occult. You have to give them iron and folic acid. Renal insufficiency, which is a very important component. Patients present with oliguria, ascites reaccumulation. There, fluid restriction, sodium restriction becomes the mainstay. Hepatic encephalopathy, where patients present with altered sensorium, and where you have to do protein modifications and branch in amino acids. The assessment parameters are many. You have clinical examinations, weight, height, Z-scores, body mass indices, mid-arm circumferences, triceps skin fold thickness, biochemical parameters, bone density, and CT to look at the psoas muscle thickness, and so many other parameters. And I will not go into all those because it's a topic on its own. These are some examples I wanted to show you. Look at these, bite spots. We detected white hot spots on day 1, and after 7 days, it cleared from the eye. These are very severe corneal ulcers due to vitamin A deficiency. Here is a child with hypoammonemia. You can see the leukonychia, half and half nail, where the tip of it is pink, but the bottom part is white. There is dry skin and essential fatty acid deficiency. This is rickets. If you can see, the bones are bent and the X-rays showing ricketic features. This is fatty liver disease, where you can see acanthosis nigricans and xanthoma. So these are the clues that we get. I'm sorry, my slides are not moving for some reason. There's something wrong with my slides. They're not moving. Okay. Okay. So in acute viral hepatitis, like Dr. Ghoshal has said, the family restricts everything, and it's not right to restrict. We should give lavishly. And the nutrition advice that is given to the child ultimately leads to punishment for the child itself. Regarding neonatal cholestasis, we have to understand that 90% of what we eat are long-chain triglycerides. Now, medium-chain triglycerides are one such type of triglycerides which do not require any role of the bile salts and are directly absorbed into the system. These are C10 to C6, and they are directly absorbed into the portal circulation. And they give about 8.3 calories, and they are very good for weight gain. There are some commercial preparations that are available in India in the form of oil and powder and infant formulae, and I won't go into the details of the same. But natural dietary items contain a lot of MCT, such as coconut oil, which is 65%, and palm oil, which is about 54%. When you have to supplement neonatal cholestasis patients, you have to supplement with higher doses of fat-soluble vitamins A, D, E, and K than normal, and these values are all available over the internet. Water-soluble vitamins, the dictum is that you should double the dose and give it in cholestasis than what you give normally to children. Protein restriction in encephalopathy, on one hand, you need muscle mass. On the other hand, you'll end up with hepatic encephalopathy. So what is best needs to be seen. If you look at the American Society of Liver Diseases recommendation, they are saying during an episode of overt encephalopathy, transient reduction of the protein is acceptable. But thereafterwards, once the encephalopathy has gone, then you should give about 1 to 1.5 grams per kg of protein. And you should not restrict because it will lead to sarcopenia in the patients. What is the choice of protein? So in the International Society of Hepatic Encephalopathy has said vegetable or dairy-based protein is a lot better than animal meat because animal meat contains a lot of sulfated amino acids that leads to mercaptans and indoles that precipitate encephalopathy. Plus, on the other hand, vegetable-based contains a lot of fiber and a rich source of fatty acid short chains, which are very good for energy. If you look at branch chain amino acids, then branch chain amino acids are leucine, isoleucine, and valine. And there is an imbalance with the aromatic amino acids in chronic liver disease. What happens is the aromatic amino acids are the ones that cause the false neurotransmitters which cross the blood-brain barrier and potentiate the hepatic encephalopathy. Hence, the trend is to give branch chain amino acids more than the aromatic acids. If you look at what the ASLD guidelines have said on branch chain amino acids, then they say that the branch chain amino acids is actually the second or the third line of therapy after pharmacotherapy. That means those patients who are refractory to pharmacotherapy are best managed by branch chain amino acid addition. And the dose of that is about 0.25 to 0.5 grams per kg in children. In cirrhosis and ascites, The problem is there is going to be salt intake, and salt intake, as you know, will give rise to ascites. If you restrict salt, the food is not palatable. If you stringently give salt, then you might lead to a lot of complications. So what is best? So again, the American Society recommends that during the time you have ascites, you must restrict the sodium at that point of time to approximately 88 millimoles per day. 1 gram of table salt contains 17 milliequivalents of sodium, and restriction of the sodium is about 1 to 2 milliequivalents per day in an infant and 1 to 2 grams per day in an adult. When you look at the sodium in dietary items, then as you see, the table salts, all your packaged and shelved products, bread, and all the other products contain a lot of sodium. Vegetables contain very little sodium, so that is well accepted. Now coming to the second part of my talk, the first part was on cirrhosis, and the second part, which is unique to children, is metabolic conditions. So the nutritional intervention in metabolic condition are of three nature. One is you target the ingestion, like in galactosemia, you want to give a lactose-free diet. In fructose intolerance, you want to give a fructose-free diet. Or you target an end product. For example, in glycogen storage disease, you can't make glucose, so you give cornstarch to make glucose. The third is to target a toxic product. Like in tyrosinemia, you want to restrict tyrosine and phenylalanine restrictions. Then you have a fourth and ancillary role that is supportive in addition to the pharmacotherapy, such as cholestasis, as in medium chain triglycerides, Wilson's disease, where you restrict the copper, ascites, you restrict the salt, and hepatic encephalopathy, you can supplement the branch chain amino acids. If you look at specific liver disorders and interventions in India, you have to see that age-wise, if you look, galactosemia and fatty acid oxidation defects are predominant in the first few years of life. In the later years, you will have Wilson's disease, glycogen storage disease, hereditary fructose intolerance, and citrin deficiency and urea cycle defects can actually present from any time in the childhood. When you look at Wilson's disease, you have to understand a lot of copper comes through our diet, and majority of the copper is actually lost in the feces. A small proportion is actually taken into the circulation and bound to the musculoskeletal system. What happens in Wilson's disease is you do not have ceruloplasmin, so the copper does not have any other compound to bind with and goes and deposits in the tissues. So what do you do in Wilson's disease? In Wilson's disease, pharmacotherapy is the first choice. Dietary copper is just ancillary, but nevertheless, dietary copper is important. These are some of the dietary items that contain a lot of copper, and ASLD says that you should avoid them in the first year of therapy till the time you're giving proper chelation. Thereafterwards, there is no stringent restriction of a copper-restricted diet. And in the drinking water, the supply needs to be a little less with copper. We concur with the same, and I would suggest you can read this Wilson's disease guidelines that we have published in the Journal of Clinical and Experimental Hepatology in 2019. And in that we concur with what they have said, except for the fact that in India, the dietary copper content as per the National Institute of Nutrition is a little different than what we have in the West, in America and other places. In our country, the red gram and the soybean are the ones that contain a lot of copper. The rest of the lentils actually do not contain so much of copper. And all the other items that you see here are taken in such small quantities that actually speaking, they are not containing high copper content. So the rest of all the items in India, as per the National Institute of Nutrition guidelines, they say that the copper content is not too much in our food items. Now, the next condition we look at is galactosemia. Galactosemia is a condition where the patient does not have the galactose 1 phosphatidylidyl transferase enzyme. So he cannot metabolize the galactose, and the galactose becomes toxic and gets deposited in various parts of the body. So what you need to do is give a lactose-free or a galactose-free formulation. Now, in children, that becomes a major issue because you're stopping milk from the diet. Now, to undo that and to supplement that, you have various permutation and combination. You can give a casein-based formula, but that's not recommended because that gives a lot of galactose in the body. So what do you have? You have a soy-based formula. Soy-based formula contains very little galactose, but the problem is soy, as I will show you in the next set of slides, soy is not recommended less than 6 months of age, and galactosemia is one such condition which presents from the neonate up to 6 months of age. So what you have left with you is a hydrolyzed formula that contains very little and negligible amounts of galactose. Now, galactose restricted diet, you can restrict fruits and vegetables, but you see fruits and vegetables do not contain much of galactose as much as it would actually harm the patient. Endogenous galactose production is much, much higher, and hence this is much more toxic. So people question how much vegetables and fruits should we restrict? You see, for you to have a very severe disease, you must eat 600 mg of galactose per day to get a very severe disease. 600 mg of galactose is equal to 7 apples, 2.5 kilos of tomatoes, and 12 grams of peas. Now, in a normal diet, we don't eat that. Hence, in galactosemia, it is not useful to restrict fruits and vegetables. I would also again suggest that there is a paper we've published on galactosemia, and we've looked at the long-term outcome of the same. And in that, we have seen that those patients who have been compliant on a lactose-free diet have actually done very well in follow-up. A very small proportion have some significant developmental delay, but the liver becomes totally normalized. This is a galactosemia family who's been following up with us for years together, and the family wants to actually, they are with us wherever we promote galactosemia. This is the index boy. The first 3 children died. This is the index boy who is now grown up, and now he's actually 10 years of age. And you see how well he has become on lactose-free diet. And this is the asymptomatic sibling. The father always pleads to us that please spread the message of galactosemia in all across India. Glycogen storage diseases, the major types in children are type 3, type 1, and type 4. Here, not a lot of glucose is produced and everything gets stored. The mainstay of therapy is cornstarch, and cornstarch is containing alpha-1 and alpha-1,4 and 1,6 bonds in the ratio of 20:1. And what happens is when you give this cornstarch, the salivary and pancreatic amylases break down the alpha-1 and 4 linkages, and the brush border enzymes slowly, one by one, like chopping in a factory, it breaks the alpha-1,6 linkages. The cornstarch therapy is a complex starch with low glycemic index. It has slow digestion with sustained glucose release. You can give it as a nasogastric drip or infusion pumps if the patient has severe hypoglycemia, or you can give it intermittently, which we do in our setup, 4 to 6 hourly, and this is recommended in children. The dose is 1.75 to 2.5 grams per kg per dose, and this should be indigenously brought, not the packeted cornstarch, uncooked and dissolved in cold water. The other dietary modifications that we do for glycogen storage disease is in DSD1, we restrict the sucrose, that means you don't give the table sugar, and the lactose, that means you don't give milk. And we give, in GSD3, we do not have this restriction, but we give a lot of protein, 3 grams per kg, because this is a disease that has inherent muscle breakdown also. Hereditary fructose intolerance. This is where the fructose does not get metabolized, and hence it causes hypoglycemia. And there, the patient, because of the fructose load, has GI symptoms such as vomiting and diarrhea, and may also have liver symptoms. It can be anywhere from deranged LFT to acute liver failure. Patients have seizures and hypoglycemia. The dietary therapy in that is, other than the fruits and fruit juices and table sugar that we restrict, we also restrict a certain degree, a certain amount of vegetables. But what is allowed is glucose powder, lactose, and all the meat and fish and eggs. Tyrosinemia is again a very complex condition where after a certain point of time, there is a enzymatic problem, and that leads to hepatotoxicity and neurological crisis. And in that, again, there is a dilemma. On one hand, we need phenylalanine and tyrosine for body growth, and at the same time, this phenylalanine and tyrosine gives hepatotoxicity. So what we do is we block it with a pharmacological agent known as nitisinone, and then we do a dietary restriction. So the dietary therapy is in an acute crisis, you're giving a tyrosine-free, phenylalanine-free diet. And then once the levels are falling, you introduce the breast milk and the infant formula, and you titrate in such a way that the plasma tyrosine and phenylalanine levels come to a normal level, and then you give a tyrosine and a phenylalanine restricted diet. And it has shown that this sort of a dietary therapy will also improve the renal tubular function in these children, but it may still continue to give hepatocellular carcinoma in the long run. So in conclusion, diet and liver disease, if you look at, on one hand, we have science, we have therapy, we have diets, which reduce the morbidity and mortality. But this comes with a very high price. There is cost. It is a problem of palatability, comfort, compromise, and quality of life. Thank you.
Thank you, Dr. Monik, for the excellent presentation. You touched every aspect of the topic very nicely and gave the take-home messages very clearly.
Thank you.
Uh,
I'll go on to the next one, ma'am.
yes.
Can I go on to the next slides?
Yes, yes. Please proceed.
Okay. So the next part is the luminal disorders. That means those related to the gut. Again, the nutritional and intervention disorders in children target 3-4 areas. One is you target ingestion, like celiac disease, allergies, FODMAPs, which Dr. Ghoshal has very elegantly shown in his slides on irritable bowel syndrome. Or you can target an end result, for example, Crohn's disease, where you give exclusive enteral nutrition. And the third part is you target a toxic product, where in celiac disease, people are working how to give wheat and yet have enzymes that can break down the glutenins. If you look at lumen and kidney, madam, this is a very big challenge you had given me. I could not find too much of correlation. With liver, there are many conditions that have common liver and kidney problems. But the gut and kidney, I had to really think hard. The non-infectious conditions are very rare in children. But these are some of the ones I could come up with. Chronic diarrhea can give rise to hypokalemia and tubulopathy. Celiac disease can give rise to type 1 diabetes mellitus and diabetic nephropathy. Celiac disease will give rise to renal tubular acidosis. Vasculitis can lead to nephritis and intestinal ischemia. Functional constipation. Well, you'd be surprised to know that this can cause vesicoureteric reflux because of a bladder bowel dysfunction. The myopathic variant of pseudo-obstruction give rise to megacystis. Drugs like NSAIDs can at the same time cause GI ulcers and interstitial nephritis at the same time. Ileal Crohn's disease can give rise to oxalate and urate calculi, and systemic mastocytosis involves GIT and kidneys. And these are all the conditions that are prevalent in children. The rest of the conditions like amyloidosis and all are not seen in children. and mostly in adults. If you look at the specific luminal disorders where dietary intervention has been advised, so you will see that bovine milk allergy is one of the disorders that present early in childhood, and in the later part of the childhood, you will have things like irritable bowel syndrome, Crohn's disease, celiac disease, lymphangiectasia, functional constipation, and others. But in the earlier part of the childhood, you can have GERD, gastroesophageal reflux disease, congenital diarrheas, and food protein allergies. Let's look at GERD or gastroesophageal reflux. In gastroesophageal reflux, the child is absolutely normal and he's just vomiting small quantities out. The mother gets distressed, what to do? In the West, they thicken the feeds, and thickening of the feed is done by a rice cereal-based diet, which has wider whole nipples so that the child can easily suck. It improves the visible regurgitation, decreases the crying episodes, and decreases the number of regurgitation days. You have to give frequent and small feeds so that there is less gastric distension and less hiatal reflux. And the third is, which is very, very controversial and is a last resort, is using hydrolyzed formula, because they say GER may be a symptom of cow's milk protein allergy, and I will show you what cow's milk protein allergy is, where a trial of an amino acid or extensively hydrolyzed formula is given. If you look at GERD in older children, then I have nothing much to advise to you, except for the fact that don't give bedtime snacks because it causes nocturnal reflux. Weight loss measures in obesity, small meals, avoiding fats and chocolates because that can lead to the lower esophageal sphincter relaxation early. And in addition, they advise, though it's not very scientific, but they advise avoiding citrus drinks, spicy foods, coffee, tea, cold drink. Capsicum, which contains capsaicin, which can also give rise to stimulation of gastric secretion and various other things, but there's not much of scientific data on the same. Eosinophilic esophagitis is one such condition where you have a 6-food elimination diet of milk, soy, eggs, nuts, fish, which gives 40% clinical improvement. Thereafterwards, they give an oligoantigenic diet, which is not practical at all in children. Thereafterwards, they move on to extensively hydrolyzed formula. And lastly, an amino acid formulation, which can give rise to 50% histological improvement. But you have to understand that diet is not the only thing is eosinophilic esophagitis. Majority of the patients will require pharmacotherapy in the form of steroids. Let's look at celiac disease, and celiac disease is one such condition which is prevalent now in northern and southern India. Wheat, rye, and barley. This is the classic celiac belt, which Dr. Yacha had described many, many years back. And initially, he showed the northern part of India, and we started progressively southwards. And now it is reported in Assam of a prevalence rate of 1%, as well as in Tamil Nadu and various other areas. What is happening is that there is a dynamic population mixing for job, for marriages, for so many other things. So the celiac belt is growing. The treatment of celiac disease, as you know, is a strict, lifelong gluten-free diet, and we have to be dogmatic while advising our patients on the same. You stop wheat and barley. Rye is not available in India, so we don't have a problem with that. There are diet charts that are widely available, and you support them with hematinics, multivitamin, and calcium for the first few months. In children, this is how the progression takes place after you have implemented a dietary therapy. So initially, there's a well-being, generalized well-being. You have symptom resolution, weight gain, height gain, a pubertal spurt, and you can avoid long-term complications. There is resolution of anemia and improvement of bone density. What is the role of a dietitian and a physician? Once you have diagnosed a case, it is important to counsel, give gluten-free diet, and closely follow up the patient. And each time you call the patient, you have to re-counsel at each visit, reassess the diet, and have vigilance. The counseling in celiac disease, the mother plays the pivotal role. She's the central role. She's in the kitchen. She can cook for the child. The other family members need to also play a good role in this. You have to understand the patient has to have a lifelong gluten intolerance. 1 gram of gluten is equal to 1 kg of gluten, so you can't even give a little bit. It has to be a dedicated, extensive explanation of the diet. And once in a while, you should hold camps and meeting to reassert what you want to see. Most parents will ask you, can I allow a little once in a while? The vehement answer is no. The effect of giving 1 grain and 1 bag is the same effect. Long-term complications will take place. And some patients, unfortunately, develop intestinal lympho and malignancy. And this is something that is not acceptable. How to make a child feel special on that diet? You have to understand that everybody should be a part of it. So we must encourage gluten-free food for all members on the weekends. It's like having a picnic or a party. Let's all not eat wheat today. There should be a reward for resisting temptation in the initial years. And once you have given that reward, once the patient tries, once he becomes understanding, it will become a habit within the child not to have any gluten. You are not alone is a phenomenon that we have to explain to the child. We have to organize camps and meeting, and celiac disease societies in various parts of the world have give a lot of morale and confidence on the same. How do you elicit compliance at follow-up? Now, child-centric questions you must give. Initially, the child will be overwhelmed in front of the parents and not give you any clues if she's quietly eating gluten or not. So you have to twist the question and ask. You ask the child a leading question and you see the rapidity of the response. First of all, you ask, do you share tiffin in school? Then she says yes. Then you say, does your friend, say her friend's name is Neha, make very tasty parathas? And then she will say yes. The moment she says yes, that means there is a breach in compliance. You have to catch hold of that. And you have to explain to the mother, and the mother will have to explain to the school teacher that that is not allowed. Similarly, they go back home and, in some kind of celebration or a birthday or something, they will have chocolates and cake. So you ask, how many chocolates did the uncle give you last week? And then she will say 5. And the moment she says 5, you catch hold of the mother once again. And then you say, see, there is a breach of compliance at your home itself. The common mistakes and solutions. Market paneer not allowed. It contains flour, suji. So you have to make homemade and indigenous paneer. Juices, which are thickening agents, these contain gluten, so the juices need to be homemade. Tinned products and preservatives need to be stopped. Toffees, you cannot give. You can give the clear candies like Mango Bite. You have to use a chakki, which is dedicated grinder at home. If you use the commercial chakkis, which is clean or washed, it still contains wheat particles. And this is where most of our patients are having breach in compliance. The compliance is going to be worse during puberty, during peer pressures. And most often, the problem arises when the children go to the hostels or the messes. So it becomes a huge issue there, how to cook. Persistent diarrhea, the dietary therapy is the cornerstone of management. The dietary algorithm in persistent diarrhea, diet A used to be low lactose, diet B used to be a lactose-free, and then you had a diet C, which was a monosaccharide-based diet. These are available widely on the internet and various other areas. And this was one after the other. It was a sequential diet that we use when there's a failure of response. But right now, the algorithm has changed. With the introduction of hydrolyzed and amino acid formulas and elemental diet, we have done away with diet C and restricted ourselves to diet A and B. And there is a bypass of a green banana diet that we can use in these patients. Reduced lactose is basically nothing but a cereal based where you have milk, sugar, and rice powder with water and oil. Lactose free is where you do not have the milk, but you have glucose and you have egg white or chicken puree, but this might not be might not be tolerable by the vegetarians. Then you have a green banana diet, and the basis for use of green banana diet is that green banana contains an amylase-resistant starch, which is delivered into the colon and gives rise to short-chain fatty acids. And short-chain fatty acids contain are the ones that will increase the salt and water absorption, provide energy, and have a trophic effect. So what you do basically is you take raw green bananas, maybe 2 bananas, and instead of going through this big slide, what I'll say is take 2 bananas, put it into the pressure cooker, 2 whistles, remove the pulp, homogenize the blend, add some rice powder, some oil, and your job is done. And green banana diet has been shown to work very, very well, especially in the persistent diarrhea patients most of the studies are carried out in Bangladesh. Monosaccharide diet, I don't believe much in it, but so I'll skip the same. The other condition that you have in children is lactose intolerance, where lactose load is in the diet, in the gut, and lactase enzyme is not available in the tips of the villi because of a recent diarrhea or something like that. And the lactose is unabsorbed, it goes to the colon, and it gives acidic and osmotic stools. What you see in lactose intolerance is a very, very bad perineum. This is an infant with, if you can see, he has a very bad perineum where the bottom is totally red, it's excoriated, the child is in excruciating pain. These usually follow a secondary episode of an acute diarrhea or sometimes persistent and chronic diarrhea. Our advice is to give 2 to 3 weeks of lactose. The reason is because the tips of the villi are usually denuded in diarrhea. They take about 2 weeks to recover and the lactose to come back. And the lactose is usually the lactase enzyme is on the tips of the villi. It's a very fragile enzyme, and that takes about another 1 week to come back. So hence 2 to 3 weeks of lactose is our advice. You can, during that time, change over to soy feeds or low lactose feeds, continue breastfeeds, and introduce complementary feeds. There are some disorders, like I have shown you in neonatal cholestasis, that require medium chain triglyceride supplementation. One of the important ones in gastrointestinal system is intestinal lymphangiectasia. What is intestinal lymphangiectasia? Basically, it's a problem, abnormal lymphatics. These are congenital dilated lacteals. And what happens is when a long chain triglyceride comes and sits into these lacteals, it enlarges and it breaks and it gives rise to chyle engorgement and ruptures, leading to protein losing enteropathy. In intestinal lymphangiectasia, what is very, very important is to give a low long chain triglyceride, high medium chain triglyceride, and a high protein diet in the child. Now, normally, if you look at a balanced diet, carbohydrates contain 50 to 60%, fats are 25 to 30%, and proteins are 15 to 20%. In this condition, what we usually do is we reduce the fats to 3 to 5% of the calories, and most of it, 85%, we try to bring it out of the medium chain triglycerides, because you understand medium chain triglycerides are the ones that are directly absorbed without the help of lacteals. When we implement medium chain triglycerides in primary lymphangiectasia, what we usually see is that 60% will just recover on this. Partial recovery is there in 20%. The rest, they might not improve and you might need pharmacotherapy in them. In IBD, you have to understand the primary problem of IBD is there is a protein energy malnutrition that is taking place in the baseline because of nausea, anorexia, cytokines, malabsorption, gastrocolic reflex. Patient doesn't want to eat because he's in pain. And ultimately, if you see, most of the children eat only 50 to 60% of the expected calories. The mean height is more than 8 centimeters below the target height. So that is a very, very bad sign. So one of the ways of controlling Crohn's disease is using exclusive enteral nutrition. This is the first line therapy in pediatric guidelines. 85% achieve remission for 6 to 8 weeks. Thereafterwards, they're put on a pharmacotherapy. And this, what happens is, by this, there is a steroid sparing effect. It promotes intestinal microbiota because of its prebiotic effect, alteration of pH, and direct interaction with the epithelial cells. The benefits of exclusive enteral nutrition are improving the nutritional status, the bone improves, the mucosal healing takes place, and there is a significant delay in starting immunosuppression, so you are having a steroid-sparing effect. What are the types of feed that are advised in exclusive enteral nutrition? People have tried polymeric, people have tried semi-elemental, elemental formula, and they find that there is no difference in efficacy of the same. Oral versus nasogastric tube, people have tried and they've shown similar results. The normal duration for which you have to give this is about 6 to 8 weeks. And polymeric oral feeds are preferred, which contain high protein and high calorie. What happens with starting enteral nutrition is that the moment you start extensively enteric enteral nutrition, you will see that there's a reduction of inflammation. By the 7th to 10th day, the mood and energy of the child improves, and the child has stability for about 6 to 8 weeks. About 30% go into remission for the next 2 years, and the patient is graduated out of the exclusive enteral nutrition to a normal diet. But in approximately 1 year time, 40% will relapse. So exclusive enteral nutrition is not the final answer in Crohn's disease. It is just a step in the Crohn's disease, and most of these patients will require immunosuppression in the long run. There are other dietary items that are used in IBD, but that over time has lost its charm. People started using omega-3 fatty acids, fish oil. It had inconclusive results. People use turmeric, and I believe turmeric is coming back into vogue, but so far we don't have enough literature on the same. And the fourth condition that we have is cow's milk protein allergy. This is typically an infant or a toddler who has colitis or a small bowel diarrhea and has temporal correlation with the symptoms with the introduction of milk and milk formula. Family history of allergies, the father may have asthma or urticaria or eczema. These colonic picture will show you aphthous ulcers, and there will be a lot of eosinophilic infiltration in the biopsy, and the possibility is bovine milk allergy. I want to vehemently tell you, and a lot of pediatricians ask this question, is cow's milk the same as buffalo's milk? Yes. Cow's milk, buffalo's milk, goat milk, camel milk, and every other animal milk all contain the similar antigen that can give rise to cow's milk protein allergy. The word cow's milk protein allergy is because that was the most common association in the West, and hence it is stuck as cow's milk protein allergy. It does not mean that the patient is only and exclusively allergic to cow's milk. He will be also allergic to buffalo and goat milk also. Hence, bovine milk allergy is possibly a better terminology. So you stop bovine milk and milk products. That means all the formulations also. You stop the formula feeds. You continue the breastfeeds in those patients who are breastfeeding. Give calcium supplements because you're not giving milk. In more than 6 months of age, you encourage solid food, and you can give a special formula or a soy product. But on patients who are less than 6 months of age, you need to give special formulas. So what are these special formulas? You have to understand that there are lots of formulas available in the market. You have a cow's milk protein formula, you have a partially hydrolyzed, you have an extensively hydrolyzed, and you have an amino acid formula. As you go towards the right, what is happening is the larger peptides are broken down to smaller peptides, which are broken down into amino acids. And by this, the allergenicity decreases. Once the allergenicity decreases, that means your potential, the potential to have an allergy will also decrease. So our choice is usually an extensively hydrolyzed formula. That's the first choice of therapy, and 90% respond to the same. But if in the 10%, this may not respond to extensively hydrolyzed, so you may need to give amino acid-based formulations if you have severe enteropathy or a failure of the extensively hydrolyzed formula. Soy formulation is actually not recommended because soy formulations 20% have cross sensitivity in those patients who have cow's milk protein allergy. 20% have cross sensitivity to soy allergen. The allergen that is there is corn glycine and glycine. It is not recommended less than 6 months of age as per the American Academy of Pediatrics and the European Society is concerned. In the long run, they may lead to thyroid disorders, aluminum toxicity. They have a lot of phytoestrogen, so there is a problem of sexual maturation, maybe. And there are long-term side effects which we are not aware about still. In cow's milk protein allergy, how long should we restrict milk and milk products? If it's a non-IgE mediated, when we say non-IgE mediated, we mean that there is no anaphylaxis. Normally, the IgE mediated has an anaphylaxis. That's a very small proportion, 10%. Non-IgE mediated is 90%. There, we should restrict it for about 9 to 12 months. Now, this is a self-limiting condition, cow's milk protein allergy. So there will be a time when you can reintroduce the milk. How do you reintroduce? In non-IgE mediated, you give 10 ml per kg of cow's milk. You watch for an hour. You look for adverse events, and then you slowly, you gradually increase the milk. In an IgE mediated, you give small aliquots of milk every 30 minutes. And this is usually done best in a hospital setup. You give 1 ml, 3 ml, 10 ml, and you start looking whether the patient is going to have any reaction or allergies or not, or anaphylaxis. If it occurs, then you stop immediately. If it does not, then you can gradually build up to 200 ml per day, at least for 2 weeks. Then the last condition is functional constipation. So we have to understand the urinary bladder and the rectum, they share a common area, and that is the pelvis. The rectum and urinary bladder have a good harmony by the spinal arc reflex. If you have anal stimulation, it abolishes the detrusor contraction. And if you have a distension of the urinary bladder, it increases the tone of the internal anal sphincter. In pathological conditions, what happens is that there is a disharmony of the same. So the defecation disorders have lower urinary tract symptoms. There's a disharmony, and this is called as bladder bowel dysfunction. And what happens is a big fecaloma like this will press and cause bladder instability. At the same time, if you have a fecaloma that's at the bottom, it will cause bladder neck compression and inhibit bladder emptying. I would again suggest that there is a paper by us on functional constipation in the management in children. And this management holds true in those patients also who have bladder bowel dysfunction. Other than pharmacotherapy, we are advising a high fiber diet. And in children, the formula is age plus 5 in years. And these are some of the common items that contain a lot of fiber, and we encourage a lot of high fiber. But what is most important is to decrease the whole milk intake, because these children take a lot of milk. Normally, functional constipation, these children are drinking 2 to 3 liters of whole milk, cow's milk or buffalo milk or whatever it is, which contains very little fiber. And that is the reason why the functional constipation perpetuates. In conclusion, I would like to say that when you take a clinical history, it's very, very important in luminal disorders to look at the response, the aggravation, and the temporal correlation of diet, how it has changed the course of the disease. Specific disorders are treated with dietary elimination, like celiac disease, cow's milk protein allergy, or some of them, like lymphangiectasia, specific diet will change the course. Other disorders, there is a dietary modification, is an adjunctive role, like pharmacotherapy in GERD, functional constipation, where diet has an adjunctive role. And sometimes diet is a stepping stone for remission, example, enteric nutrition in Crohn's disease. I'd like to thank the Society of Renal Nutrition and Metabolism for giving me this kind of opportunity, and especially Professor Anita Saxena, who made me read quite a lot for this presentation. And it was a very nice scientific challenge for me as well. Thank you.
Thank you, Dr. Monik. Again, it was a very nice presentation with a very clear message to the audience. I think since we have completed all the three deliberations, we can start the question answer session.
Yes.
Dr. Anita Saxena, please, ma'am.
Yeah, sure. Dr. Moinak, excellent talk, and we really enjoyed both, sir, Dr. Yusri Ghoshal, sir. We enjoyed your talks, and I'm sure there must be a lot of questions coming up. So, do we have anything in the chat box? Chat box, any questions?
May I please ask one question, please? Am I allowed to ask one question?
Yeah, sure.
Ghoshal sir, when we try and implement a FODMAP in our own family members, it becomes impractical. So what is the right thing to do for them? How do we implement FODMAP in our adults?
You see, what happens is if you look worldwide. Yeah, I think we have to mute all the mics except the person who is speaking. So maybe if you look worldwide, yeah, somebody, yeah, all the mics indicate except the person who is speaking. Yeah, so if you, okay, there is echoing. Yeah, so if you look worldwide, the standard system is FODMAP diet is difficult to be implemented by a gastroenterologist. It is done by a dietetics fellow because the gastroenterologist's problem is you do not have so much time. Number two, obviously, your knowledge about this FODMAP and everything is not so great as a dietitian who is into it all the time. So that's why maybe our dietary practices are not the great way. If you look at the world where the FODMAP diet originated, like Australia, if you talk with Peter Gibson, he'll say it is my dietary fellow. In fact, the Holmos, the first author of the paper of Peter Gibson, is a dietetics fellow. So now what happens is we fail maybe because we try to do. Second thing, even in the Australian fellow, if you bring him to India, her to India, and say you implement FODMAPs, you will fail. The reason is look at our diet. Everything that you eat has a lot of onion, a lot of garlic, a lot of those other curry material which are high in FODMAP. But still what we do practically speaking, I have developed a website because I earlier did not have a dietitian. Currently, one of the dietitians is working with me as a research fellow, so it became better. But what I used to do for quite a long time, I have a website called www.spreadhealth.in. Now there, I actually made a FODMAP diet chart. And this chart only is a pictorial chart. Which are the foods which are high FODMAP, which are the food which are low FODMAP. And I tell the patient to repeatedly refer to this chart. Even I say, you print one copy of this and put in your kitchen or dining table. You can also save in your mobile. Now, what happens is avoid for 2 weeks or 3 weeks completely and see, are you really improving? If you are not improving, forget about this. Now, if you are improving, then what you do is that gradually introduce one at a time for 1 to 2 weeks and see, are your symptoms coming back? Now, then you find that you could identify only a few which exaggerate your symptom. Like you may identify it is the milk which is exaggerating the symptom. It is, let us say, cauliflower which is exaggerating the symptom. It is mushroom which is exaggerating the symptom, and stop these three. So this is how we implement, but I would not say this is the best way. In fact, if you look at Monash University, they have created a mobile app So that mobile app, I have seen a lot of people who are my friend, but also have IBS, but they themselves are gastroenterologists. What they do is that when they sit in the dining table in the other countries, when I go for international conference, they will open the Monas app and they will say, how much FODMAP does this food have? This is a new food they have served to me. Let me see how much FODMAP does this food have. So what happens is you put in the Monas app name of the food, even, and you find what is the FODMAP content. Now say it is small amount of FODMAP, you can taste a little bit. This is a small amount. Whereas if you have a big amount, avoid. Interestingly, all the non-veg food has no FODMAP, because you see they are very poor in carbohydrate. Like if you take meat or fish, they don't have any FODMAP. So India, this is another challenge, that basically a lot of people are vegetarian, particularly in the northern part of India. For them, taking low FODMAP is very difficult. So currently there is not a single study. There was not a single study on FODMAP diet in India. But fortunately, a study just came in 2 weeks ago, which is online fasting journal of gastroenterology hepatology from DMC Ludhiana. And they actually did it quite effectively and the result was positive. But what you suggest is very right, is very difficult. But at the same time, we tell our patient, once you know that he has allergy or he has intolerance to some FODMAP diet, you say you choose between having the symptom and enjoying those food. If you find those symptoms, what you get is too trivial, you think, but the foods are you can't be deprived of, then enjoy the food, have the symptom. But if you think the symptoms are really bad, then avoid the FODMAP. So you are empowering the patient and let him or her decide whether to have the symptom or have the FODMAP.
I think, sir, that's very wonderfully said. Only thing is that if we use a mobile app to look at the FODMAPs, all the women will get frustrated because they'll have to cook again for their husbands, probably in the kitchen.
Trained, they will get trained gradually. You see, they will get trained.
Right.
Particularly IBS patient who have very severe symptom, they will get trained.
Sir, the most important question which a patient, at least in our family, what is the most ideal cereal? So wheat gives FODMAP, rice is also FODMAP. So which cereal should the patient be best consuming?
Yeah, I tell you, rice is very low in FODMAP. Interestingly, rice is very low in FODMAP. So rice is a better cereal than wheat. In fact, rice, interestingly, if you any healthy subjects take wheat, about 6 to 8% is malabsorption, even in healthy subject. Whereas if somebody takes rice, about 2 to 3% is malabsorption. So the amount of malabsorption carbohydrate is also less with rice, and the FODMAP content is very low, particularly the rice nowadays that we take, absolutely white rice. So therefore, we ask our IBS patient, Northern Indian IBS patient, learn from a Southern Indian what they take. They take a very low FODMAP food. They take low.
By this stretch of imagination, Bengalis should not be having IBS because they eat rice and fish.
Yeah, that's right. But actually problem is, I tell you, IBS is not caused by dietary intolerance alone. So dietary intolerance contribute to maybe 10 to 20% of IBS, but the 80% not related to dietary intolerance. So what are the causes of IBS? It is a dietary intolerance. It is visceral hypersensitivity. It is stress, anxiety, and cognitive dysfunction, gut microbiota dysbiosis. So there are multiple components to IBS. So therefore, Bengalis may have a different type of IBS than the other people. Maybe if you take a Bengali population, like pure Bengali population, you try to restrict their FODMAP, they will not respond so well to a low FODMAP diet compared to a Northern Indian population.
Sir, I think since IBS, if we look at the pathogenicity, it is multifactorial. So the management also has to be multifactorial, and dietary management is one of the important component, but is not the only component of the management.
Absolutely right. That's why what we did is in the Rome 4 guidelines, we introduced what is called multi-dimensional clinical profile. So we say the moment you saw one IBS patient, Just ask yourself a few questions. Question number one, what is the diagnosis? The diagnosis is IPF. Is it functional dyspepsia? Then second thing, sorry, just have to mute one mic. Second thing, one of the mics is on, so it is equal with your mic is on. Yeah.
Another thing that comes to my mind is Dr. Ghoshal, that you talked about the changing places and the effect that it has on IBS symptoms. So I've seen that sometimes there's an old saying, कि पानी बदलने से भी दिक्कत होती है. And sometimes you find that hard water has some influences on symptoms. So have you found that in practice that there's a difference between hard water and treated water?
Your question is very interesting, but we have not done any study on that. But what I'm saying is that when you change a plate, it is well known that diet may change. Second thing is stress level may differ. Third thing, microbiota is going to change. So there are a lot of other changes happening. Very interesting that hardness of water could be a factor, but to the best of my knowledge, that has not been studied.
Do we have some questions from the audience, Dr. Anita?
Sorry?
Do we have some questions in the chat
No,
box?
no, not in the chat box. No, I think they are very happy because this time it was so purely nutritional that I think they are, I mean, most of the people are really satisfied with what has been talked and told to them by both the speakers. Excellent way of putting things together. So
I agree. It was an excellent talk, a detailed one from Dr. Mehta. So congratulations to both the speakers for the initiative.
yeah. So if there are no more questions, I'd like to thank the panelists, Dr. Nirupam and Dr. Abha, and my esteemed speakers from my own institute, Dr. Ghoshal and Dr. Moinat. Excellent session, and I really enjoyed it. And I'm sure the audience must have enjoyed and learned a lot from this one. And so the next session that we're going to have will probably be on the 7th of March, which is the first Sunday of the month. So I do hope that we are all going to be here at this platform again a month from now. And so if there are no questions, would you like me to wind up the session?
I believe so.
All right. Thank you so much, Society of Renal Nutrition and Metabolism. Thanks all the panelists, the speakers, and the audience for having joined us. And I'm sure these deliberations must have enriched your knowledge. And I'm sure you're going to use them in your clinical practice. Thank you so much, and bye-bye from me.
Thank you.
Thank you. Thank you, Dr. Anita, for inviting us.
Thank you.
It was a pleasure.
Yeah, thank you so much.
Thank you, Dr. Anita.
Thank you.